Next in the queue of the diseases, we have vascular diseases of the liver, and Dr. Muhammad Salih, who is a consultant gastroenterologist, hepatologist in Safa International Hospital and an expert endoscopist, and he will be steering us through this disease.
Thank you, Dr. Seher. Bismillahirrahmanirrahim and Assalamu alaikum. I'm really indebted to the PSH for giving me the opportunity, and more so to Professor Kashif Malik and Dr. Zishan. I'll be talking to you about the vascular liver diseases and no disclosures. We know that vascular liver diseases is a heterogeneous group, as the liver has both portal inflow as well as arterial, and then we have got a very good or sort of hepatic outflow in the form of hepatic veins. So portal vein thrombosis, Budd-Chiari syndrome, and there are so many other, you can go through the list, including even the rarer one, the obliterative portal venopathy, and of course some of these were touched yesterday by Professor Ghayas already. So we will discuss only these two because of the time constraints. It's customary to just briefly discuss about these intrinsic and extrinsic pathway, which leads to the common from vector. Later on, they converge along with the platelet activated platelets would lead to thrombosis and clot formation. However, we have moved to the cell-based model of the clot, where because you cannot separate them out, everything is happening at the same time. So platelets along with the tissue factors, and in combinations whether the procoagulants or anticoagulants are activated, and you can see some of them are in the rectangular form, which are the anticoagulants, while others are in the oblong circles, which are the procoagulants, and the continuous lines or the prothrombotic one or activate them, while the dotted lines are basically inhibitory pathway. So that's how a clot is being formed, and that's how our hemostasis or the fluidity of the blood is maintained in the normal health. And if there is a tissue trauma, then a clot is formed. Hemostasis in cirrhosis, we also know that lots of changes are occurring, and there is decreased synthesis capacity because of the loss of the hepatocellular cell capacity, and would lead to both decrease in the pro and anticoagulant factors as well as in the fibrinolytic factors. To couple this with more or make it more complex, we also see that there is qualitative and quantitative deficiency of the platelets due to the decreased thrombopoietin as well as sequestrations and accelerated turnover of the platelets due to hypersplenism. But to an extent, this has been sort of maintained by the increased productions of this endothelial cells, hemostatic proteins. The plasma levels are increased by the endothelial cells, and somehow or other this will help to overcome the relatively qualitative and quantitative deficiency, and that's how even when cirrhotic bleeds, clots are being formed. So by this cartoon, one can say that in the healthy liver, we have got a pretty much bigger area to maintain the balance, but even this balance is maintained in the cirrhosis, but one can still see that how precariously this balance is maintained in the cirrhotic patients. And there are factors which may tilt in the cirrhosis, either to the bleeding tendency or to more clot formations, like if there is a renal failure or infections for instances, so these patients would bleed more. On the other side, if there is endothelial activations or altered blood flow as the portal hypertension progresses, then we may see more thrombosis. Now this brings us to a question: is cirrhosis a prothrombotic and a procoagulant or an anticoagulant state? And this is contrary to our conception that these patients are autoanticoagulated, because the aggregate data points to hypercoagulability in these patients rather than anticoagulations, and especially as the portals, more so in the portal circulations, and where portal flow decreases as the portal hypertension worsens. And the recent data have correlated increased productions of the von Willebrand factors, as we alluded to a little while ago as well. In these cirrhotic patients, the endothelial related factors are increased in cirrhosis. More so when the portal hypertension worsens, as we see in the cases of worsening ascites, increased incidence of varicose hemorrhage or bacterial infections. And all of these would lead to decrease overall transplant-free survival rates. So, and there's also, one may also say that whether venous thromboembolism is common or uncommon in cirrhosis. The incidence of venous thromboembolism is probably as it is in the non-cirrhotic, and in fact, in population-based data suggests that probably it's a little more than the general population. Now, the venous thrombosis in cirrhosis we will be discussing, we are not discussing about the arterial thrombosis. So it will be the bland portal vein. We can have a bland portal vein thrombosis. Even malignant thrombosis are there in the cirrhosis if they have hepatocellular carcinoma and Budd-Chiari syndrome. But we will be only discussing these two, not the malignant one. Now, we know that the incidence of this portal vein thrombosis increases, and once you diagnose these patients, it's around 5% in the first year, but it increases to more than 40% at 10 years. And more so as the liver disease progresses, the incidence of this would increase, or the prevalence would also increase, and somehow or other NASH-related cirrhotics are at more high risk of thrombosis than the cirrhosis due to other etiologies. So what are the risks for these? Of course, one more thing is that even if the thrombus is non-malignant, please do look for intra and extrahepatic malignancies, because this may be just telling you something, that something is lying over there. So the risk factors are intra-abdominal infection, some recent intervention, as well as including the one at times we inject them with hysterectomy and all that, which is also associated with that. Prior incidences or history of the venous thromboembolic phenomena, thrombophilia, and of course, as the portal hypertension worsens, the low portal vein flow velocity. The presentation is variable, and the stability, regressions, or resolution appears more common than clot progression. But once it progresses, then probably it will lead to further complexity. And even it is recommended that a small partial thrombus in a branch may not be treated for that matter, but you need to monitor it at least. So cirrhotic patients with portal vein thrombosis, how do we diagnose them? We diagnose them through Doppler ultrasound and a dynamic CT scan and MR, and these patients with portal vein thrombosis only, and if there are no previous history of venous thromboembolic phenomena, one may not screen them for thrombophilia and all that, because it's probably only due to the liver cirrhosis, not other causes of thrombophilia. So, and the diagnosis with an ultrasound, which is confirmed with the dynamic CT scan and MR, not only confirm, but we also need to know that where the thrombus is, and the location of thrombosis should be documented not only for clinical but for future research purposes, so that we also know that how our therapy against the thrombosis are working. And it's not only the location of the thrombus, but the clot length is also important, that how much is an intrahepatic, extrahepatic, what was the length of it. Also, one needs to document at the outset that what % of the lumen is a complete occlusion or is partial or incomplete, and if it is partial or incomplete, is 50% or less than that. So one needs to document this also. Now, the prognosis, there is still controversy whether non-malignant portal vein thrombosis impact for prognosis, because majority of these patients, unless and until it's related to an event or will be, or in the setting of a previous thrombophilia, they would have advanced liver disease already. So there is a little controversy, but we do know for sure that technical complexity of the liver transplantation surgery is the main reason behind that one needs to address this issue, because it adds to it and may have a negative impact on the transplant outcomes later on. Now the treatment, anticoagulations with heparin, more so with the low molecular weight heparin, appears safe and effective for portal vein thrombosis and cirrhosis. Now, what about the oral therapy? We know time-tested warfarins or vitamin K antagonists. And the newer directly acting antiviral, the new directly acting oral anticoagulants seem reasonable alternatives treatment as well. And some data is now becoming available. Probably they may be better than the warfarin, but we should not conclude and start treating everybody with the DOACs. Before starting anticoagulation, one needs to screen these patients for esophageal varices and dealt accordingly. And one more thing which we are worried at times about, the bleeding risk, but the bleeding risk is rather lower on anticoagulation if you are taken care of the portal hypertension. So don't worry, please, if you want to treat them properly and early. Now, when to treat, the decision to intervene rests on few things: that the extent of thrombosis, the presence of and absence of attributable factors to the symptoms, and the risk of bleeding and falls in these patients. So one needs to also address this issue. One may not treat all thrombi in such situation, not otherwise. Venous thromboembolism, of course, that needs treatment. Now, when to treat, the guidance is lacking, but as the data is still emerging. But we do know that treatment is more so indicated though in those patients who are liver transplant candidate, as we know that this may add to the complexity later on and may have even lower outcomes. So patient with acute portal vein thrombosis, heparin infusion can be used in hospital setting and followed up, of course, by either low molecular weight heparin or DOACs. In compensated cirrhosis only, we don't have good data in a decompensated cirrhosis on DOACs. The duration of therapy, the changes in the portal vein thrombus would appear within 2 weeks if you image them at interval. However, somewhere between 3 to 12 months of therapy has been tried, and we know that with this we may achieve partial recanalization in more than 2/3 of the patients, and around 42 to 53% of times we may have a complete recanalization with 6 months of therapy. So what happens if there is an incomplete resolution of the on anticoagulation? So what we can do is we may extend the therapy, we may switch to another class of anticoagulants, and of course one may think of another method which may be a which is TIPS or transjugular intrahepatic portosystemic shunting. Now we move on to the next topic, which is a Budd-Chiari syndrome. We all know that it is characterized by obstruction of hepatic veins outflow anywhere from the small hepatic veins to the junction of inferior vena cava and the right atrium in the absence of intracardiac or pericardial diseases or obstruction. This has been already showed to you yesterday by Professor Ghayas, but we know that if you work them properly, in 2/3 to 3/4 of the times you will find a cause of the Budd-Chiari syndrome or etiology of Budd-Chiari syndrome. We know that it's a rare disease. However, the incidence is around somewhere 1 case per million person years, and with a prevalence of around 1.5 to 7 per million. Diagnosis, of course, is based on imaging. The first one should go with the Doppler ultrasound. You need to confirm the diagnosis with MRI and CT scan, and you need to discuss it with an expert. If the suspicion is high, but your initial imaging or the initial reports are negative for it, one. Second, you also need to talk to the interventional or the expert radiologist, so that one should be looking for short strictures or obstructions, because they are amenable to treatment very well. The treatment of Budd-Chiari, of course, initiate therapy for complications of portal hypertension as recommended in cirrhotic otherwise for ascites and GI bleed for instance, and treat all Budd-Chiari syndrome patients with anticoagulation in the absence of major contraindications. And portal hypertension complications should be treated as you treat them in an otherwise situation, and specifically more so if there is no contraindication to the anticoagulation, so you need to anticoagulate them as well. And up to 1/4 of these patients with Budd-Chiari syndrome may have a 5-year survival on medical therapy alone, but you should be selecting them properly. Treat them with the unfractionated or low molecular weight heparin, vitamin K antagonist, or even the DOACs in the right setting. Now, if if you discuss it, then the next thing is that vascular intervention and consider angioplasty and stenting as a first line procedure, more so in patients with short hepatic vein stenosis or inferior vena cava stenosis. Though the incidence of such patients is low in Caucasian as compared to the Orientals. The shunts, now probably the shunt surgery has gone down as we have more versed now with the tips, and it has taken over, and tips with the PTFE covered stent is the treatment of choice where venoplasty fails or is not an option. Dips may be required, which is the directly connecting inferior vena cava with the right portal vein, may be needed in 40% of the times, and one can achieve a reasonable transplant-free survival rate, 5 years survival rate with the tips or dips. Surgical stenting may be considered in selected patients where tips has failed or not feasible, more so in patients where you are infrahepatic IVC to the atrium gradient or suprahepatic IVC to the atrium gradient is high. Then in those cases, tips may not work. Now, liver transplantation as salvage treatment for patients in whom medical treatment, venoplasty or stenting or the tips or dips or shunt surgery is either not possible or have failed. And we have data that the LDLT data is small, but still one can have more than 70% survival rates if in properly selected patients. However, majority of these patients would require lifelong anticoagulation after liver transplantation. So this was also shown to you yesterday by Professor Ghayas. So this is a stepwise approach to a treatment of Budd-Chiari syndrome. Which to start with medical treatment, you look for angioplasty stenting, and even at times in hyperacute or acute thrombus, if one can do thrombolysis, that's also IR based. And tips omitted the shunts, the surgical shunts, because majority of patients are now taken care of by our interventional radiologists, and of course liver transplantation. The only thing I would say, liver transplantation, if you are facing with an issue of a portal hypertension, then think of decompressing the liver. A simple word. If there is hepatocellular failure, be it acute or chronic, liver transplantation. That's, I can say, that's the whole crux of the Budd-Chiari syndrome. So, ladies and gentlemen, I will conclude with my next 2 slides with take-home messages. For portal venous thrombosis, cirrhosis is rather a procoagulant condition. Cirrhotic patients at risk of DVT may be prophylaxed even. Screening endoscopy should be performed before starting anticoagulation. Liver transplant candidates should be anticoagulation for portal venous thrombosis. Unfractionated, low molecular weight, warfarin or DOACs are the treatment options. Cirrhotic patients are at low risk of portal hypertension related bleeds on anticoagulation if you have taken care of their varices. The take-home messages for Budd-Chiari syndrome is a rare liver disease, vascular liver disease, but needs early recognition. Multidisciplinary and stepwise treatment approach is recommended. Selected patient may require only medical therapy with accepted outcomes. Early and successful vascular intervention may result in good transplant-free survival rates. And liver transplantation should be considered in hepatocellular failure, be it acute or chronic, or even at times where other therapy fails or as a salvage therapy. Thank you for your kind listening.
Thank you, Dr. Mohammed Saleh, for compacting so nicely what was a very vast topic.